Hello, everybody, and welcome to another edition of the PSS Podcast. As usual, I'm joined by the PSS team. We've got Anita Plant, our CEO.
Morning, everybody.
Got Gary Flack, our optometrist.
Good morning.
And I've got Nikki Johnson as well, joining us, our mental health and wellbeing practitioner.
Hello everyone.
So today, we're going to be talking about a really quite a large subject. It's diabetic eye conditions. So, Gary, can you just explain a little bit about diabetic eye conditions?
Yeah, there's quite a few. The biggest one is diabetic retinopathy. It's a big word, but it just means that the retina is leaking blood onto the retina, and that's usually seen when you have either an eye test or a retinal screening done within National Health. And there's various stages of retinopathy. You also have maculopathy, so that's the centre part of the vision which can be affected as well. And not everybody has that problem, but certainly, generally speaking, if your diabetic control isn't up to scratch, then it will manifest itself, and that little retina that we've got is very, very thin and can get damaged quite easily. So it's really important to keep on top of the diabetic control. But yeah, so maculopathy is where it affects the centre part of vision. That's quite a bit more serious. There are other treatments for that, and it's definitely important to have an eye test regularly.
Yeah. Anita, you want to jump in there?
Yeah, I know, Gary, you've always said that when you're examining people's eye, you always said to people that looking at the retina and with people diabetic, that it's the only organ in the body where you can actually see all those tiny blood vessels.
Very much so. Those tiny blood vessels on the retina are also in your liver, your lungs, your heart. So if we are, as a profession, seeing the damage to the retina, then it's probably going to be damaging other parts of the body, and that makes it harder to keep control of the diabetes. Yeah. So it's kind of a window to the body's health, if you like. Yeah.
Really important to get regular eye tests.
Absolutely, and isn't there a national screening programme that helps?
Yeah, there
be
is.
able
The
to monitor
NHS
that?
have set up a national screening in the UK. Various areas have different protocols. For instance, in Doncaster, you go to the hospital to actually have a photograph taken. They put some drops in your eyes, make your pupils bigger. Other places, particularly more out in the sort of sticks, as it were, they have a man in a van that actually comes around to see you. And then other places actually have retinal screening done in doctors' surgeries. So the idea of that is that it doesn't matter where you are in the country. If you move from Doncaster to Plymouth, those retinal images should follow you. Whereas if you go to an optician, if you kind of hop around each optician every year, those images tend to stay with the practice. So you're not getting the continuity and seeing any changes in the eye. Whereas the NHS one, they will be able to access that at any point.
So it's quite like a dynamic range of conditions, isn't it? So it can change from a week-to-week basis, kind of.
Yeah, and in fact, with the diabetic retinopathy, initially the blood vessels do leak a little, which then it's a bit like having rice paper and having water on rice paper. You'll end up with a sort of a watermark, and that's not very good for the retina. But if it gets worse and worse, then the body actually tries to repair itself, and it's pretty rubbish at repairing itself. So it creates these new blood vessels that are very leaky, which actually makes it even worse. So, and when you get to that point, the vision definitely is going to be affected quite a lot. Yeah.
So can I just say, so what's the mechanism within the blood that would cause those blood vessels to leak?
It's the diabetic control being yeah. So if you have too much sugar,
yeah.
So it's not necessarily sugar, but it's glucose. It's how the body deals with that, such that if we kind of say that the body's under stress because of the diabetes, because it's trying to deal with all of this sort of swapping sugar and storing it and then bringing it back out again when it's needed, the body hasn't got the time to repair itself very efficiently, and these blood vessels, rather than the big ones that you can see in your legs and your arms, they're really, really much tinier, and they only have probably a few cells, and they don't have any muscle structure. So as soon as that cell comes away, then the body's just hasn't got time to repair itself, and that's when it starts leaking, which then is a bit of a vicious circle.
So then if you're eating more sugar,
Yeah.
that's going to
And we do crave sugar, unfortunately.
And
so
then it's sort of
it's a
like that
vicious
cycle,
circle.
isn't
Yeah,
it? Yeah, absolutely.
But also the body emits a chemical to help repair itself, which goes into the gel that's inside the eye. So even though you might be getting on top of the diabetic control, that gel still has the bit that tells the body to make new blood vessels.
So would the person then experience floaters and things called
Potentially, but yeah, I mean, then we get into the realms of having to have surgery for that, which is removing the gel and putting in a new gel. But again, it's all hinged on the fact that if you can keep on top of that diabetic control, which I appreciate is not an easy thing to do.
Yeah, so we're talking about how the body kind of tries to repair itself. Can any of the symptoms of retinopathy, anything like that, be reversed? Or?
They can. Again, you're back to it's an eye condition that's led by the diabetes. So if you get on top of the diabetic control, we're going to see less of a problem on the retina. And there are other conditions that occur. We talked about retinopathy, but it can lead, if you're diabetic, it can lead to earlier cataracts. Those develop a lot quicker. Also can affect your colour vision a little bit as well. So things that are bright red are not bright red to you because of the diabetic control side of it. And also there's other factors like a higher risk of glaucoma as well. So it's not just the blood vessels on the retina, there are other things that you're getting on top of that. So the key part to it.
Is high blood pressure a factor as well?
To some degree, yes, but again, it's that comes because of sometimes the diabetic control, and then that pushes the pressure
The
up.
whole system, isn't it?
Yeah, it's the whole system really. And usually in the UK, once you've been diagnosed as being diabetic, even if your blood pressure isn't high, you usually put on blood pressure tablets, statins to keep the cholesterol down, to keep the blood vessels open, and possibly some blood thinners as well. So, but again, the key to it is trying to get on top of diabetic control if you can. It's kind of a lifestyle change rather than leaning on the medication factor. Of course, age is another factor as well. So
I was quite surprised because my brother-in-law has diabetes, type 1 diabetes, and so when my husband went to his health check, he was told that his chances of getting it was something like 40% higher because of the family
history as well. And there are other factors as well. So African, Caribbean, they tend to be diabetic a little bit earlier and things like that as well. So there are other factors with it, but being diagnosed as being diabetic is not the end of the world, and you can actually reverse it. In fact, we do have a colleague who's gone from being diabetic to pre-diabetic recently, so that's actually good news.
And that's been controlled.
But that needs a lifestyle change.
Yeah.
That's the a
and
big
it's
change. Really,
big commitment as well. We know that our colleague there has changed pretty much everything about his lifestyle.
And we crave sugar, so it's a Western culture as well.
I was going to say, the Western diet, it's kind of preloaded towards high sugar, high fat diet. So
processed food, that's a whole.
That's so whatever's really tasty is really bad for you. So
I know.
We're set up to fail, aren't we?
I think the other thing is education as well. That the amount of people that you see that don't understand, they kind of think diabetes is an eye problem. But if you then say to people, actually it's a body problem that shows up in the eyes, and you can do something about it, that sometimes it's like, seriously, I've not heard that. So education, I think there's a little bit of a lacking. There's some areas that do quite well at putting people onto nutrition and dietitians to have a chat about it, and about what foods are good for you, what's really, really bad for you, even the difference between green bananas and ripe ones. And ripe ones can have about 3 times more sugar. It's just that education, isn't it? Knowing that if that's the case, then what to avoid.
So we're talking about lifestyle and everything like that. So Anita, you deal with a lot of people who've got this obviously in their daily lives. How do you find, in your experience, diabetes and diabetic retinopathy in particular interacts with people's daily lives?
So how it sort of functionally affects them, Okay, so I think it depends how long they've been diabetic for and how it's affected their vision. So the one thing with the diabetes is if it's affected all those spine blood vessels, it will have affected the feet, the nerves in the feet. So sometimes that will mean that the person, because they're not feeling things so well through their feet, they might be unstable. So there'll be a little bit of unsteadiness when they're walking around, which can affect their gait, and which can then lead to sort of like mobility issues as you're walking skew, which means that you start getting sore hips and backs and more falls and things like that. The other thing with while we're on that subject is that if it's also affected your vision, and as Gary said, by the time it's affecting those small blood vessels in the eye and you can see it there, it's likely to be having some kind of effect elsewhere. So that neuropathy in the feet, if you're not seeing so well, you might not be noticing when you've got an issue with a toe, maybe you've got an ingrown toenail or something that has become infected. Because you can't see it, you might not notice it, and because you can't feel it, you might not notice it. So that is sometimes an issue. So making sure that you have regular like whole body checkups. A lot of diabetics get part of that as part of their diabetic screening. But so mobility wise falls, being aware of that. If you're not feeling things so well, you might be unstable on your feet. The other thing as well is if you need a magnifier, if it's affected vision, you need a magnifier. You holding the magnifier because you might have lost some feeling as well would be a little bit awkward and uncomfortable. So it's looking at alternate ways of doing that. If it's affected the again on the retina, it depends where you've had those little bleeds. So if it's been in the peripheral, that would affect your nighttime vision. So going out at night, you would experience more problems with that. So being night blind. So again, thinking about, if I'm going out at night, do I need to take perhaps a torch with me, or you might even find you might need to be use a long cane or some kind of mobility aid or so on. And then of course if it's been a maculopathy, so it's affected the central vision, that will mean that seeing detail will be a problem. So things like your reading letters, reading posts, just any reading you're wanting to do will be harder. So it's looking for those.
What your blood sugars are, reading those.
Yeah, absolutely. So reading, self-monitoring, you need to check your blood sugars, but how can you see what they are if you can't see properly? So and to be honest, there have been various kind of talking glucose monitors that have come and gone. But there doesn't seem to be, as far as I'm aware, and we had a quick look before we did this podcast, any kind of one device.
Yeah. So with some of the newer technologies where there's a little pad that's on your arm, and then you use a mobile phone to actually read it. Those are they're coming along line, but they're quite an expensive way of doing it. And again, it's trying to roll that out to people.
It's not suitable for everyone, is it?
No.
As well.
And again,
it's not a one-size-fits-all way of managing it, is there?
No. What you could do is if you're able to use smartphones and technologies, to utilise Seeing AI or similar apps like that. So if you take your blood pressure reading, if you're doing a prick test and you've got the reading but you can't see the LCD screen or anything like that, is utilise a smartphone. You can either use the camera to magnify into it possibly, or like I say, Seeing AI can it can do a text read, so it can read what it's seeing. But it's not available for everybody either, so it's not a full fix either.
There are ways around it, and I think that's what we try to do, don't we, in our clinic, is we try to sort of say to people, well, let's see what we can do to help you do what you need to do and to help you manage your diabetes.
Have to be quite creative at times.
Yeah, absolutely. I think the other thing, if I can just say quickly as well, one of the other problems is because it's a body problem, it's a fluctuating problem. So you might wake up in the morning and you feel okay and it's great and I'm going to go out and everything, and then your sugar drops and then you start, the vision will drop and then things will get tricky. So I think that's also being aware and know your body, so that if you are perhaps going to have quite an active day, make sure you've got your stuff with you or your glucose with you, that you can, if you are beginning to feel a bit woozy, that you can just add in some sugar to stop you getting the blood sugars going low and creating an issue. But it will fluctuate. That's the one thing with diabetes vision, it tends to fluctuate. And you agree with that, Gary?
Yeah, it does. Yeah, definitely.
So I think as well, when people are having eye tests or glasses, it's like you kind of have to be aware that it fluctuates.
It is one of the first questions when I know that someone is diabetic when we're doing an eye test, is how is your control? Because if I find quite a big shift in the prescription and you start prescribing new glasses, only to find out the blood sugars are way out of kilter, then that's why the prescription has changed. So I would kind of perhaps talk someone through the diabetic control first, and then see them back again to decide whether that same prescription's available.
Because otherwise you can spend an awful lot of money on glasses or magnifiers and things, and it's a movable feast.
Yeah.
So it's always quite a challenging thing.
It is a challenge,
Yeah, talking about control then, Nikki, you interact with quite a lot of people. I think we've got the conditions associated with diabetes. Do you feel that people you interact with have what's their general control like? Is that affected by their mental state as well, possibly?
Yeah, I mean, I think it's really important to kind of acknowledge that it's a long-term condition for most people, and it's a lot to ask anybody to have to monitor everything that they eat and drink and do, and all of their health conditions on a daily basis. Lots of us are fortunate that we don't have to think about those things constantly, and there aren't often ramifications for us not thinking about it. But if you're diabetic and you're not managing it well, it does have ramifications. There are kind of poor results that can come from that. So I think, just considering that and how, it's a mind-body connection here. So if you're not managing your diabetes well, it can often lead to poor mental health. If you've got poor mental health, that can often lead to not managing your diabetes well. So it's a very much a kind of backwards and forwards, and for lots of conditions, people are able to go to the GP or the hospital and get some form of treatment, and the treatment does its thing. With diabetes, it's very much a self-guided, self-initiated process for keeping yourself healthy and well. So it's arduous, it's a lot for people. There's a really big kind of mental health aspect here because it's overwhelming, and then on top of that, if you've been told that you've got diabetes and then you go to a clinic and you're now told that it's affecting your vision, it's another layer. And it's also a layer that you can't get away from, because often if you've started to notice those changes in the vision, you might not always notice the changes in the body, and that's why you carry on doing the things you're doing and perhaps not managing things as well as you could. But then you go to hospital, you're told you've got retinopathy or maculopathy, and you can see it. So you wake up again knowing that, there's an issue. And I know all of this sounds quite grim, and it's not always this grim, but it's just something that we, I think, as people working with people with diabetes, just need to be aware of and a little bit mindful that we always mean well. We always kind of are trying to encourage, good, healthy, activities and processes, but actually sometimes it's part of the reason why people don't keep up with their screening. They don't come and get those photographs.
Comfort eating, isn't it?
Absolutely. Because some people may feel, what else have I got? So it's really difficult. I think just my advice for people really is notice how you're feeling, and it's okay to be feeling overwhelmed. It's really, really common. If anybody with diabetes is far more likely to actually have mental health conditions like anxiety and depression. So really noticing how you're feeling, finding people to talk to about it, opening up about it, seeking, mental health support through your GP or through, charities like ourselves. We can help with the, that aspect of sight loss that you might be dealing with. And just, don't keep it in.
I suppose you need to be in a good place in order to feel in a good place. And it's that vicious circle.
Absolutely.
I think talking to our colleague who's managed to, turn it around for himself, I think the fact that he is a bit of a stubborn.
He is stubborn.
He is very stubborn. So
he doesn't mind me saying it. He's stubborn.
Diplomatic of you.
Which is good.
But he kind of took it on almost as a personal crusade. That's it.
Yeah.
I'm not gonna. This was something that he saw it as something that a challenge for him to take on. So. So for him, it's almost, and it's had other positive effects on his life. The fact that he changed his lifestyle has led on to feeling better about a lot of other things as well.
Yeah.
So sometimes it can be like a wake up call that kind of
Absolutely.
like a call to action almost.
Yeah. And I think, I know we're not going to kind of go into too much detail on this, and rightly so, but there's obviously type 1 diabetes, type 2 diabetes, and there's lots of other types actually. And I think for those people with type 1, it can be a bit slightly more challenging in that, you know, that kind of, I can control this just with diet is maybe not an option.
No,
I can fight this is maybe not an option in the same way that it is for somebody with type 2. So I think there's so much to consider here, isn't there?
Yeah, very much so, yeah. In fact, the NHS about 10 years ago went through a phase of saying, you know, empowering the person with diabetes and started handing out blood glucose monitors. And I think that the idea was to kind of reduce the workload on the doctors so that you could manage your own dealings. The problem was that, I mean, the body does need sort of ups and downs. It can't really cope with this very flat line, you know, always under the sort of Zen type thing, because even on a daily basis it alters. So people were actually becoming too overwhelmed by the fact that they're having to keep checking, and actually I've got a bit of a headache, I'll check again. And actually that's not good for your well-being, mental health well-being.
It's not, no.
You're kind of just adding to the frustration
and also I think, you know, just from working in the eye clinic, you know, a lot of the advice that would come out is, you know, changes for the long term are always better than those big sweeping changes that make really drastic drops or ups in the kind of levels that you've got, because actually that doesn't always help the eye condition. You know, I mean, is that right, Gary?
Yeah, very much so. I mean, you know, so I'm diabetic, so I go on a diet. That's not what you need. That's definitely not what you need. You need to look at what you're eating, how you're eating, exercise, and things like that to sort of stave off any of the problems that we've talked about as well. So quite as I said, it's a big subject. Certainly from an eye point of view, it's a massive subject. I think also we must remember the Parish Society, we obviously see people that are quite advanced in terms of the diabetic issues, whereas, you know, if I do work in normal practice, and so 7 out of 10 people that I see that are diabetic don't actually have any eye issues, you know, and probably never will, because they do manage it. So it's not a case of saying if you're diabetic you will end up seeing us because you've got these big problems. But it's important to head it off at the pass before they come to that problem. Yeah.
So can I just ask if there is a lesion retina, what treatments do they do?
So the treatments for any of the eye conditions?
Yeah, any of them related to diabetes?
Quite a lot. I mean, the cataract one is the easy one. If you develop cataracts earlier, then removing the cataracts and putting an artificial lens in. Glaucoma, obviously, there's treatments for that as well. If you have the problem where your body is making new blood vessels, and these are the leaky ones, they can use laser technology to actually sort of affect that particular area to help other areas have more blood supply. It's difficult to do it on a podcast, to be fair. But also we talked about that gel that's inside your eye. There is a thing where they can actually remove the vitreous and replace it with new ones. So those are the treatments, but to be fair, when we are talking about that type of treatment, your vision, you have been well affected by the diabetic side of it. So I'd much rather talk about how we can stop it rather than the treatments for it, because you're way down the chart on that one,
Prevention's always better than the cure, isn't it?
Yeah.
So.
Absolutely, and it's just so important that people do, you know, we go on about it a lot on these podcasts, don't we, but they just keep up with those screenings, those checks, because often for those new blood vessels that you talked about, they may start in the periphery on the outside of the vision, and you may not notice straight away, and they're happening, they're going on, they're not something that you're aware of. And so that's where those screening programs really do help pick things up early, so you know, before it gets to the point where you've got bigger problems.
Just a point on the, you know, do you need an eye test in opticians as well as the retinal screening? And the answer to that is yes, because the retinal screening do look for other things like the pressures in your eyes, so that's leading to glaucoma. They're not quite as in tune about the vision at the hospital. So again, it's, you know, seeing these big shifts in prescription, that would tell me that, although you might tell me your diabetic control is okay, I've got a feeling it's probably not. And the NHS actually do fund that sight test, so it's not a free test, it's a test that you can go to an optician's. My philosophy with that is that it should be every 2 years, unless that optician that you're seeing thinks that there can be some issues that might be like the early glaucoma and things, or the pressures are going up, or you're changing prescription, in which case they're quite open to, you know, make it a yearly appointment. And I've had people where they've come for an eye test at the regular opticians and massive pupils, and when did you last have your diabetic screening? Oh, this morning. So it's not a good idea to kind of put those two close together. And my kind of philosophy of that is if keep the appointment for your NHS screening, don't mess around with that, but maybe suggest that the sight test is done maybe 6 months after your screening, so that if it's a yearly screening and a yearly eye test, there's someone looking at your eyes every half year rather than two people doing the same thing in the same day. So, you know, have a chat with your optician when you see them. If everything's okay, ask if you can sort of push it out a little bit further.
Yeah, and often with the screening services, you know, just for reassurance really, if they do find something that they feel then does need treatment, there's quite clear diabetic pathways into an ophthalmology service, into an eye clinic service. So that will happen quite swiftly, and then the sort of medical retina consultants will pick that up and take that forward. So
very much so.
it's usually quite a slick service, which is why that screening programme is so important.
Excellent. I've pretty much hit all my points, I think. Does anyone else have anything else to add to this?
We're good.
No, I think we're good. If anyone's
Got to be careful not to
questions.
overload people with information, haven't we, as well? So,
That's it.
yeah, but if anyone does have any, if you listen to this and you've got any questions or concerns, the Partially Sighted Society is here for you Monday to Friday, 9:30am to 4pm. So if you've got any questions that have arisen from this podcast, or you think we've missed something, we're more than happy to try and help. So, yeah, contact us Monday to Friday, 9:30 till 4pm on 01302 965 195, or you can visit our website, that's partsight.org.uk, or follow us on social media as well, and that's at Partsight. So, nothing left to do but say thank you to everybody. That's Nikki, Anita, we've got Gary as well. Thank you very much, guys.
Thank you.
Bye,
Thank you.
everyone.
See you on the next one.
See you on the next one.
The information provided in this podcast is intended for general knowledge and informational purposes only, and does not constitute medical advice. The content is not a substitute for professional medical care, diagnosis or treatment. Always seek the advice of your ophthalmologist or other qualified healthcare provider with any questions you may have regarding a medical condition. Do not disregard professional medical advice or delay in seeking treatment because of something you have heard on this podcast. The Partially Sighted Society does not endorse any specific tests, treatment or procedures, and information provided on this podcast should not be considered as such.